The broadcast is now starting. All attendees are in listen-only mode.
Hello, my name is Mike Willett with the National Native Network, a program of the Intertribal Council of Michigan. Welcome to the NNN webinar series on cancer risk reduction in Indian Country. This webinar is titled Food is Medicine, Clinic-Led Food Security Initiatives in Navajo Nation. This technical assistance webinar is being hosted by the National Native Network with Indian Health Service Health Promotion and Disease Prevention, which offers technical assistance and resources for commercial tobacco and cancer prevention and control throughout Indian Country, and the Indian Health Service Clinical Support Center. Your presenters today are Karen Bachman-Turner, MPH, RD, CDE, CSOWM. She received her bachelor's in 1978 in nutrition from Washington State University and her MPH in 1980 in public health from University of California at Los Angeles. Since 1980, Karen has worked continuously as a public health nutritionist or health administrator, including serving as a project officer for the Special Diabetes Program for Indians grant for the Indian Health Service. Her specialties include diabetes treatment and prevention, including diabetes in pregnancy and interconception care, and obesity treatment and prevention. And Dr. Sonya Shin, MD, MPH. She received her Bachelor of Arts in 1992 in Literature from Yale University, her MD in Medicine in 1998 from Harvard Medical School, and her MPH in 2004 in Clinical Effectiveness from Harvard School of Public Health. Dr. Shin's work has focused on global health issues and health equity. She has worked for more than 20 years with the International Global Health Organization, Partners in Health. Her work is focused on demonstrating the value of community-based healthcare delivery. Since 2009, Dr. Shin has collaborated with the Navajo Nation and Navajo Area Indian Health Services to improve healthcare delivery. She is the founding director of a nonprofit organization, Community Outreach and Patient Empowerment. No commercial interest support was used to fund this activity. This activity is designated 1 contact hour for nurses and physicians. To obtain a certificate of continuing education, you must be registered for the course, participate in the webinar in its entirety, and submit a completed post-webinar survey. Survey links will be emailed out following this webinar within 1 hour after the presentation. By the end of this webinar, participants will be able to utilize the IHS Food Insecurity Screening Questionnaire to identify at-risk populations, apply cross-sectional initiatives to address food insecurity and improve health outcomes in local community, and employ community clinic interprofessional teams to address health equity through social determinants of health. And now at this time, I'll present Dr. Sonya Shin.
Good afternoon, everyone. This is Sonya Shin, and it's really just a pleasure to start off this webinar. I'm just going to advance the slide here. So I think many of you are very familiar with the challenge of food insecurity across Indian country, and I wanted to provide a little bit of context of what food insecurity and food security feels like in the communities that both Karen and I serve here on Navajo Nation. So this map might be familiar to you. It's the USDA food desert map, and you can actually click onto USDA, and it's an interactive site. You can see clearly that Navajo Nation, which is sort of the outline of the pink area, is classified largely as a food desert. And we've read in literature that 75% of households report food insecurity. But we were also interested to understand, well, what does that feel like for families themselves? And when we did community interviews with individuals living in Eastern Navajo, highlighting some of the information that we learned, that most families travel more than an hour to buy groceries, and there are many families, 1 in 4, who actually are only able to buy groceries once a month. And using the USDA Food Insecurity Screening Questionnaire, that 1 in 4 families report that they're actually skipping meals due to a lack of money. And for those of you who have ever done home visits, I think that it often is really helpful to go and visit with families, patients in their homes, because that also gives you a really, I guess, just a much more real sense of what challenges with food access might feel like. So I actually wanted to just share this photo, which was actually published by Al Jazeera when they profiled food access and food insecurity in Navajo Nation. This is a gentleman who is living with diabetes, and you can kind of get a sense of what food insecurity might feel like if you can only get to the grocery store once a month, that you're often going to be shopping to buy things that will last you throughout the month, that won't go bad, and are going to be calorie dense and nutrient poor. So as you can imagine, this is sort of what day-to-day life might feel like, and the challenges of living with diabetes are magnified when your choices of healthy food are extremely limited. I want to kind of go back, though, to the map of the food insecurity desert, and just to highlight again the fact that, as you can see from here, it's actually almost uncanny that the borders really map completely across the borders of the Navajo Nation reservation boundaries. And the reason I wanted to sort of call this out is because we have to sort of remember that food insecurity, as with many social determinants of health, are actually things that are constructed. They're social phenomena, and many of the factors that really drive limited access to food insecurity on Navajo Nation and other reservations are policies, forces of industry that promote sugar-sweetened beverage. So for instance, in many places on Navajo, it's probably easier to get a hold of a Coke than it is just a glass of water that is considered clean and drinkable. And for that reason, I just wanted to sort of emphasize the fact that social determinants of health are constructed through economic, policy, historical decisions and factors, and so too they can be deconstructed by intentional efforts that engage multiple sectors to overcome and reduce challenges such as food insecurity. I'm going to pass it over to Karen to chime in on maternal health disparities.
Hello, it's my pleasure to be here today with you. I work as part of a team in the high-risk prenatal clinic at Northern Navajo Medical Center in the northeastern corner of that map that you just saw of Navajo Nation. And just to talk a little bit about the maternal health disparities that we see here. There'll be some slides coming up, hopefully. There we go. There we go. So unfortunately, we do see increased trauma and stress among our prenatal population. This is about 1.7 times the national average. We see about 2.5 times higher moms who are late to care or for prenatal care or have no prenatal care, and about 1.5 times the rate of diabetes among our moms. And also the food insecurity, about 1.5 times higher. Our moms are more likely to face food insecurity during pregnancy. About 20% of the moms is the data that we have so far, and we're tracking that, and we'll have some updates on that as we go forward. But as you can see, a lot of challenges for moms during that vulnerable prenatal period. I'm having trouble advancing my slides, it looks like. It worked perfectly during the trial, so let's try this. Oh, here we go. Sorry. I might have advanced too many slides there. Nope. Okay, we're good. Sorry. So when we had the opportunity to consider using the Fruit and Vegetable Prescription Program, or FVRX, which we started about 4 years ago here, we looked at some vulnerable populations to receive these benefits, like prenatal patients and children. And over those 4 years, we found really positive impact from the program. For the providers themselves, it's helped us create partnerships that probably would not have existed otherwise. We have doctors, nurses, nurse midwives, dietitians actively involved in the entire fruit and vegetable prescription program, from enrolling patients, doing the monthly education, but also reaching out to the community grocery stores, gas stations, farmers markets, wherever our patients might be obtaining their food. And as Sonya said, it could be a real challenge in many cases of patients having to drive long distances and having very limited food choices. But we formed a team here of providers, multidisciplinary providers, who are implementing the fruit and vegetable prescription program. And one of the most exciting things for me about this program is that it really empowers patients to be successful in their own, managing their own health, and giving them the tools to actually go out and obtain fresh and frozen fruits and vegetables. And it's been really exciting to see how the patients have embraced this program and really use it to their best advantage. And I will give more examples as we go on. But we also partner with the retailers in the area, and again, made partnerships with them that probably would not have existed if it weren't for this program. The communication between the clinical programs, the local grocery store, has been greatly expanded. We have providers working in the grocery store on the weekends and evenings doing demonstrations. They built a little display to give away free fruit as patients or as customers enter the grocery store. So all these systems becoming much more involved with each other, more communication, more collaboration, and all resulting in a better supply of fruits and vegetables across Navajo Nation. Initially, when I went into the local stores, there might be like one little brown banana and a wrinkled little cucumber, or very little selection. This is New Mexico, so there was always frozen chili in the freezer, and there was usually a bag of potatoes, but very little selection as far as fresh and fruits and vegetables. And so with this program, with FVRX, it creates a demand for the programs because our patients receive vouchers every month to go in and use like cash to purchase fresh or frozen fruits and vegetables. And the retailers agree to stock more and have a wider variety. And some retailers have really embraced this concept, added coolers, really made significant changes to the produce that they offer. And so that helps not just the participants in the FVRX program, but everyone living in that community, because now the whole community has better access to fresh and frozen fruits and vegetables. So just overall, working together, just helping the entire community. And sorry, I'm searching again to advance the slide. Here we go. So how do fruit and vegetable prescription teams get started? Here, we were approached by COPE staff who presented the program to staff at Indian Health Service, explaining what the program was, what our role would be, and what the advantages could be to our patients. And then staff at Indian Health Service, and often pulling in other staff like community health representatives, other programs in the area like Johns Hopkins Family Spirit Program, the State of New Mexico Firstborn Program, who are making home visits to very high-risk young families. Anyone with an interest was welcome onto that team, and again, formed a new collaboration. And we received training from COPE, how to implement the program. And COPE handled all of the store agreements, and they handle the payments to the stores. And that was probably more of a challenge than forming our clinical teams, because the clinical teams were pretty excited about this program. We really thought it would benefit our patients, and we couldn't wait to get it started. Then the recruitment phase starts of recruiting patients to participate. Here, we chose high-risk prenatal patients, and there's also a pediatric group. It varies a little bit site by site, but we thought that intervention with the high-risk prenatal population is a really critical time in the lifespan to make a difference that could affect even generations to come, because if mom is healthy during her pregnancy and having a healthier baby, if her blood sugars are in better control, her weight gains in the appropriate range, the chance for a healthy baby is increased. And we'll talk a little bit more too. One thing that we've seen that we think is pretty exciting is that we've been doing this long enough now that moms are coming back and saying that the children that they had while they were enrolled in the fruit and vegetable prescription program have different food preferences. They will eat any vegetable presented to them. In fact, they're asking for vegetables. We now have, moms are coming back and saying, my children ask for celery, or my kids love those little things that look like little cabbages, and they're like, Brussels sprouts, your kids like Brussels sprouts? And they're like, yes, they really ask for them. And some of our highest risk families have the most amazing responses. One family came back and said, we bought a vegetable steamer because we're eating so many more vegetables today than we used to. And so the feedback from the participants, from all the partners, the clinical partners, the retailers, has all been so positive that we definitely are glad to be a part of the program and hoping to expand it. But the FERX sessions themselves, some groups have classes and that meet each month. We started with that in the prenatal clinic, and we've now gone to just enrolling individual moms as they're identified in the prenatal clinic. And so we have a kind of an individual education session with each participant rather than group, but that can be adapted to meet the needs of the site. Let's see if I can get this next slide to work. No. Mike, it looks like.
Yeah, the map. I think we're not able to see the arrows. Thank you. So I'll kind of chime in here too. This is just a map of the different hospitals with the little H's across Navajo Nation that are offering FERX, and then the little bubbles are the stores, the retailers that are actually participating. And I'll talk a little bit more about how we've been working with stores as well. But I did want to present a little bit of our preliminary outcomes. And I want to emphasize that this wasn't a research project. This was really just an effort to roll out a program and to be very flexible as to each of the clinical team's needs and priorities. But we did manage to do surveys of the families, the participants at the beginning and at the end. So among the pediatric groups, so these are kids enrolled up to 5 years of age, you can see that they were on average about 4 years old, so preschool age. The household size is quite large here on Navajo Nation, and using the USDA instrument to assess food insecurity, very similar to the published data that 77% of the households were food insecure. 60% of the children who were enrolled met qualifications for overweight or obesity, and you can see that many of the households were participating in food assistance programs. And this is kind of the information, the pre and the post, among just those kids who were enrolled initially with a BMI that classified as overweight or obese. And what you can see is that at the beginning, about 40% of the children were overweight and 60 met criteria for obesity, whereas by the end of the 6-month program, 38% of the children had actually gotten to a healthy weight classification. In the maternal cohort, we were able to look at changes in fruit and vegetable consumption. And these findings are actually quite similar between the kids, the maternal cohort, meaning the children's fruit and vegetable intake, and the maternal. In both groups, we saw that the average intake of fruits and vegetables increased significantly by the end of the program. So Karen alluded to the fact that we are working with these small stores and the grocery stores, farmers markets, basically all of the folks who are available within the Navajo community as places where people can get healthy foods. What we tried to do is really to address that troublesome map at the beginning that we talked about of food insecurity by raising the level of supply of fresh fruits and vegetables, especially at these small stores. So this is an example of the produce refrigerator that Karen alluded to in a local trading post. It's called the Tisnas Trading Post. It's in a very, very rural area. And our team has provided technical assistance, partnership. Sometimes we've been able to secure funding to purchase some of these equipment so that the stores can actually implement the changes that they feel capable of doing to offer more healthy options, better quality as well. And this is actually just to give you a sense, the dots are, it's a map portraying the stores on Navajo Nation based on a CDC EpiAid evaluation that was done, I think around 2012. And what we've done here, you can see that there are green dots, yellow dots, and red dots. The red dots are the ones that don't meet minimum stocking requirements for fruits and vegetables at that time. And the yellow ones meet kind of a basic acceptable threshold, whereas the green dots are the ones that are actually stocking more variety of healthy fruits and vegetables. And what we're trying to do is really work with all of the 120 some stores on Navajo Nation so that we can overall get all of these dots to look green. What we can see, this is circumstantial data, so we can't say that this is specifically due to the initiative, the Healthy Navajo Store initiative, but at least what we've seen is that from the baseline survey that we did, the bottom bars in 2014, and then the most recent survey that we did last year, the number of stores that are actually meeting the criteria for either excellent availability of fruits and vegetables or good are increasing, whereas the stores that were really classified as basic are actually going down. So that's, I think, promising in terms of really trying to get at the overall access at the population level for healthy food.
So in conclusion, just to try to wrap up our experience here, the fruit and vegetable prescription program, we knew our patients faced real challenges with access to food, the long distances they had to travel, the low income, the other socioeconomic challenges that our families had. But we knew that was the case, but we were surprised by how successful this program has been. We've reaped benefits that we never imagined would have been possible. In one way, just from the intake form that participants completed to enroll in the FERX program, we were able to see the food insecurity that was self-reported by participants. And based on that, we began 100% screening of all new prenatal patients, asking them about food security, and have developed a template to use in our EHR to document that. And we use the 2 questions that the Food Insecurity Assessment tool that is actually posted on the Indian Health Service Division of Diabetes Treatment and Prevention website. And we would definitely have more information if anyone wanted to know about that. But we're now starting to track and follow all prenatal patients and start to address the issue of food security in a more organized way. The other things that have been really exciting about this program is that the comments back from the vendors and the participants, we have owners saying how much they appreciate being part of the process. I hear back from participants when they go to the local grocery store how helpful they are and how much they really like the program, and patients feel really good and comfortable about using the vouchers in our local stores because the stores are so happy to have the program there too. We've had patients say that they'd never gone to the produce section of the grocery store before until they had the FERX vouchers that they could use. And we hear over and over from participants what a difference this makes for their family and how much they appreciate it. We have seen a positive impact on childhood obesity for the pediatric participants. The other thing that we did not anticipate for our moms who enroll during in the prenatal clinic, often their fruit and vegetable prescription eligibility extends into the postpartum period. And so we have moms with type 2 diabetes who typically would have been lost to care. No matter how much we try to get them like their follow-up appointment or get them plugged in with a primary care provider, often we would see moms with type 2 diabetes who did not come into our healthcare system at all between pregnancies. And while they might have been in great control during the pregnancy, they'll come back to us pregnant again with an A1C of 14 with no medication in between the 2 pregnancies. But with fruit and vegetable prescription, they come back every single month to get their vouchers. And that gives us the opportunity to make sure they're getting their medications, if there are any diabetes standards of care that need to be addressed, if other appointments are needed, we're able to provide that when they come back for fruit and vegetable, even though they're not accessing any other department here. And for our moms with gestational diabetes, again, they come back faithfully for those vouchers, and they are completing their follow-up glucose tolerance test to screen for type 2 diabetes. And so we're keeping them in the system. And that's been a really positive aspect that we had not anticipated. The other thing that was a surprise for me is when we offer this program and patients say, you mean I'm going to be able to get fruits and vegetables from this program? It's like we have a good relationship with our patients. We have a very friendly, easygoing clinic. It's a wonderful place. But this just took us one step more where the barriers just fell down and the interaction between the providers and the patients was different. It was much more collaborative. We're sharing recipes and just it just changed the interaction in such a positive way, because they were now getting the tools to be successful, to improve their own health and their children's health. And as I said, as we then affect taste preferences, potential for improving the health of generations to come, because these children are growing up with that preference for fruits and vegetables, those nutrient dense but not calorically dense foods that they now prefer, and are going forward, hopefully into their own healthy pregnancies and future. So while it does have an immediate positive impact of putting some food on the table for these struggling families, that long-term benefit is very important. And building those good relationships between the staff, between clinical programs in the community and the grocery stores, the farmers markets. It's just been an exciting new conversation that we haven't had in the past. So it's been a very positive program that we've really appreciated having the opportunity to be a part of it. Thank you.
And I'll just chime in a little bit about, kind of the back end of starting up a program, because I think, Karen, your firsthand experience as a provider is just, for us, what's kept us going, on the back end to just make it happen. And I want to kind of point out that FERX is this national program, but this was really the first, to my knowledge, the first fruit and vegetable prescription program that was really focused on a Native American population. And I think I just want to kind of dispel any myths that it's too complicated to actually start it up locally. I think, you can hear from what Karen's describing that the program can be flexible. So, for instance, we chose to focus on the young families, pregnancy through age 5, because we thought that, our feeling is that that's when we can have the greatest impact on health outcomes. But there has been discussion about what about elders, what about individuals that are living with other diet-related conditions such as cancer, heart disease, adult diabetes, obesity. And I think that there's a lot of room for exploration in terms of how FERX could be relevant for different communities that play on the strengths and the interests of the clinical team. The other thing I'll mention is that we've also tried to create that, embrace that flexibility in terms of how the vouchers are getting back to the community, because we see it as sort of a form of economic development for the Navajo Nation and these small businesses that are operating on the reservation. So we work with small stores, with farmers markets, we work with grocery stores as well. But I would imagine that different tribal groups might have even more imaginative ways of directing the vouchers in such a way that you could really emphasize and revitalize traditional foods that are grown locally. So our vouchers, for instance, can be redeemed for fresh fruits and vegetables as well as traditional foods. But I think that other communities, if there are strong grower collectives that are thinking about how to revitalize indigenous diet, the FERX voucher could be really effective for that. The other thing, just to kind of be transparent about just the back end of the voucher and where the funding comes from, we started off with foundation funds, but we've always been thinking about sustainability. So we've been very excited that now we have public sector funding from the state of Arizona, or Arizona First Things First. And we also have funding from USDA through the recent GusNIP grant. Special diabetes itself in some of the clinics have identified and set aside funding for the vouchers. So for us, I think we kind of grew the program in a certain way, anticipating that there would be public funding available for this in the long run. And I think it's still, to be determined how successful we'll be in sustainability, but we're very optimistic given the fact that the USDA and state funding and special diabetes fundings are now kind of operationalized as part of the program. And the last thing I'll say is just in terms of next steps for our program, even though as a nonprofit we've played a role in helping to build this up, we're really now working to transfer ownership of the FERX program to the regional network of providers. And I know, Karen, you've been really instrumental in helping to build this network. If we have about 12, 13 different clinical sites that are running the program, and they get together on a quarterly basis to discuss what's working, to share best practices, and ultimately to make the decisions around how to evolve the program moving forward. So our belief is that this could be, really just kind of embedded as part of just routine operations within the Navajo area IHS as a program that's offered across all of the sites over time. And one last thing I'll comment in the future is that we're hoping to really understand what that impact is on intergenerational health. So you mentioned how now the parents are starting to describe that their children have different taste preferences. We're hoping that we can actually be able to evaluate, how are those children going to grow up? Like, what is their own kind of growth curve, their growth trajectory going to be over time if their moms were participating in the FERX program when they were pregnant with those children. So these are all things that we're kind of looking forward to better understanding about the program. But we are just very, very delighted to be able to share our experience with all of the participants that have taken the time to join today, and would love to see opportunities to expand access to healthy foods in any number of ways across Indian country. Thanks.
All right, thank you very much for presenting. We'll open up questions until about the top of the hour, and we'll try to get through as many of the questions as possible. If you have any questions, feel free to type them into the question box. I did notice that the handout was the wrong handout that was uploaded into the system. I'll try to work on getting that fixed up here before the end of the presentation in case anybody wants to download that. But otherwise, the webinar archive and the handouts will be available at our website at keepitsacred.org. Under our resources tab and webinar archives tab. So that's where the webinar archive will be available. So our first question here says, great to see the positive results in the children after 6 months. However, 6 months isn't a long time to see long-term effects. So I'm curious to know if these children will be followed for many years out. One second here. So it looks like Karen and Dr. Shin have lost their audio.
Mike, we're back.
All right, we're back. Okay, so where we left off here was the first question. The question says, great to see the positive results in the children after 6 months. However, 6 months isn't a long time to see long-term effects. So I'm curious to know if these children will be followed for many years out.
That's actually one of the important questions that we've also discussed as a network. This is Sonya speaking, and we are hoping to follow the children who have been enrolled in the program. So hopefully over the next few years, we'll have that kind of data.
Okay. And our next question here says, I've spent some time on the Navajo Nation, and your picture of the stock store is amazing. What a huge difference. Thank you.
Thanks for that feedback.
Yeah. It's amazing. The stores are just really excited to be partners. You know, so
They
the
really
owners
are.
and the managers. We kind of thought that they would be the bad guys, but they're really not. Yeah.
And that
So,
communication between staff, the medical staff and the stores hadn't really happened before, but that's been an exciting part of the program.
So I am not able to upload the PDF of the handout. So if folks want a copy of the handout, they can either email us or visit our website at keepitsacred.org and just go to the webinar archive tab there, and everything will be up there probably before about 6 o'clock Eastern time today. So. This next question is, how has the Navajo junk food tax policy impacted your project?
Well, I don't know that there has been a direct impact here in the program at Shiprock. There have been positive impacts on the community as a whole. I don't know if specific.
Yeah, so just thank you for asking that question. For those of you who aren't familiar, the junk food tax both imposes a tax on unhealthy foods, but also allows for healthy food to be tax exempt. I would say that, you know, in a way, FDRX and the junk food tax are part of a bigger movement. It's part of a bigger movement to be aware of how people are making decisions. You know, when you're in the grocery store or in the shop, you know, what am I buying? How am I making these decisions? And the other area that I think the junk food tax has not necessarily influenced FDRX, but maybe the opposite has been, you know, working with families, they're actually really savvy. And so when they've identified that a store has actually, you know, kind of inadvertently applied a tax to an FDRX item, they have let us know. And because we're close partners with the stores, we've been able to then come back to the stores and provide some refreshing and coaching, just because I think, you know, the stores are really open to feedback, and oftentimes the tax may be applied in a way that was just unintentionally not according to the legislation. So I think that's been a nice feedback loop.
Okay, and this person says, what is the criteria for a healthy store index, and how did you assess the changes in the store? How did you track changes?
Yeah, thanks for asking. So the Robert Wood Johnson Foundation has a really nice document that's called the Minimum Stocking Requirements for Small Stores. And I'm sure you can Google it. It actually has kind of recommendations that are meant nationally. We went back and evaluated that and just made some minor modifications that we felt were a little bit easier to measure here on Navajo Nation. So off the top of my head, I can't remember it. For instance, it might be that you have at least 6 fruits and at least 5 different vegetable varieties to be classified as good, and then at least, you know, 10 to be classified as excellent. I apologize that I don't know the actual thresholds offhand, but we do go back to the stores. We have a team that returns to the stores each year and just does a quick survey using the Nem Store Survey, which is kind of catalogs the different types of fruits and vegetables, and we use that to kind of assess, you know, and rank where each store is on meeting their minimum stocking requirements. So that was really important because you know, we have made mistakes along the way. And one of the things that we did was we worked, like just an example, we worked with a little store that was really excited to partner, but they just didn't have the supply chain to be able to stock a lot of fruits and vegetables. And when the families went to the store, there just wasn't enough supply. So here we were driving up demand, but not really helping the stores to actually be prepared to meet the supply. And so that's when we decided to kind of actually formalize this minimum stocking requirement, which has been quite successful with the stores.
Thank you. And this next question here says, many Navajo ceremonies serve, quote, unhealthy, end quote, food during and after ceremonies. Are you working with traditional healers to improve food options at these ceremonies?
That's a really good question. I'm not personally working on that particular issue.
I know the Navajo Nation president, Jonathan Nez, has been very conscious about raising awareness for healthy lifestyles. And so he himself has been reaching out to traditional healers, to community leaders to begin to shift that culture towards healthier food, even at community events. An example that's not exactly a ceremony, but for instance, right now we're in fair season, and the leadership of Navajo Nation has really demonstrated a shift towards handing out fresh fruits at these fairs rather than candy, which was kind of the norm before.
Awesome. Okay, and this question here says, Shiprock is a farming community. Has the fruit and vegetable consumption spread to local farms? There's usually an abundance of corn, squash, and melons during growing season. Are people starting to grow other produce?
There have been programs, some greenhouses in town introducing other produce. And that is a good point that there are cornfields, squash in the area, and some families definitely have access because they grow their own. But again, getting that out to everyone, and especially the families that don't have those farms, has been a bit of a challenge. And I think that's why some of this work being done by COPE is helping to build those bridges to get that produce to everyone.
Yeah, I don't know, Karen, if you wanted to mention the food sovereignty efforts of Northern Navajo Medical Center. I mean, they've really been reaching out to growers too.
There are groups. As this issue, the extent and severity of the food insecurity that came to light when patients started to complete those intake forms sparked an interest. And so there's a broader coalition that's formed and it really brought in a large number of partners across the spectrum, growers, all sorts of government, tribal organizations, trying to provide better access to healthy foods and also training in how to prepare those foods. There's a native chef doing food demonstrations and helping teach people how to use the food. So there are some really exciting new activities in the area that have just in the last year or two really started to take off.
And then this person here asks, they just wanted to be reminded on when the program started and how long has it taken to see positive results that you reported.
So the program started in 2015, and actually Northern Navajo Medical Center was one of the very first sites to implement it. And I think, you know, the results, even after some families have participated in a 6-month, during a 6-month period, we started to hear anecdotes, like stories about children who were making lifestyle changes, health improved, even like grandmothers within the same family, because the vouchers, actually it's $1 per household member per day. So it's really meant to be an intervention for the whole household. But I think really in terms of the data, it's taken us a couple of years to generate, you know, the data that I just shared with you, you know, just because it took us a while to kind of collect enough data to be able to analyze.
Then this next person here says, wow, excellent program. And then they continue. In my program, I have moms who are so used to letting the children eat Cheetos. When sharing the idea of giving them fruit instead, mom usually makes a funny excuse. Oh, I'm sorry, makes a funny and excuses the unhealthy practice. How did you introduce this new way of eating to the moms and families? How did you get the children to give up the Cheetos?
I can just share what some of the moms have told me. And I wondered about that. Before fruit and vegetable prescription, I think the most frequently mentioned vegetable that moms reported the family eating was fried potatoes. And I wondered if they wouldn't use the vouchers to get more potatoes. But really, without a lot of prompting from us, they are exploring raspberries, blueberries. As I said, the one mentioned her child was asking for celery. It seems, from our experience here anyway, if those foods are available, the young children are accepting those foods and really enjoying them and asking to continue to have those foods. The older children, moms are reporting, are not so receptive to those fruits and vegetables, and that they're having to shop differently for the older children, which is unfortunate that the older children, but I think again that critical period of during pregnancy and breastfeeding, that where those subtle flavors are introduced to the fetus and then to the child that's breastfeeding, building those preferences in for those fruits and vegetables. I'm not sure if that answers your question about the older children who are used to Cheetos, but at least now there's a choice in the household that they hadn't had before.
Yeah, and I'll just chime in, Karen, I was thinking about the preschool age children. We really kind of grappled with that question too, and we adapted an evidence-based curriculum called Healthy Homes, Healthy Habits, Happy Homes. And we introduced a lot of hands-on experience for the children so that they could try new foods and new flavors in a kind of a fun, sort of just interactive way. So the children and the parents participate. There's a food demo, there's recipe sharing. Mm-hmm. And I think just even being able to incorporate those food demos where the children themselves are participating in, for instance, sampling popcorn or trying celery or broccoli orange salad. I think that introducing that kind of fun and experiential element has been really well received.
Awesome. Okay, and we've got about 6 minutes left until the top of the hour, and I do want to give a quick plug that we do have another webinar coming up this coming Wednesday, the 9th of October. However, we will not be offering CEs for this presentation. The presentation is called Powwow Sweat, and that'll be coming up on October 9th. But we are offering CEs for today's presentation, so make sure you fill out the webinar evaluation that will be emailed to you shortly. And then we can get that processed for you within the next week or so. This person asks, these vouchers seem like a great idea. How are businesses and stores able to redeem these vouchers? AKA, how did vouchers circulate throughout the community? And did the businesses receive money for participation?
Yeah, thanks for asking. And it's actually they're like literally paper vouchers that can be redeemed. Essentially, they have like sort of almost like cash value within the stores that are participating. So, for instance, like Karen, you might see a family and give them a booklet, mm-hmm. and then the family goes to the store. They have their ID card and they use the booklet, and then the store will submit an invoice to our team with the receipts and the booklets so that we can then reimburse them full value for the purchases. So that's kind of, the stores don't get an additional incentive to participate, but they do get full reimbursement for the vouchers.
And then this person asks, are there other Native Nation groups attempting similar programs?
I'm not aware of any other sites.
Me neither. If there are, we would love to hear from you and be able to kind of exchange ideas.
And then this next question says, you discussed how policy drives health disparities. What recommendations do you have for tribal clinic staff to approach tribal leadership in regard to creating policies? For example, limiting access to soda in gas stations.
I can take a stab at it, and then you know, I think for those of you who are able to participate on the webinar a few weeks back, the junk food tax, which is I think a really important policy here on Navajo Nation, probably couldn't have been passed without the support and input of providers from Indian Health Service who were able to actually share the data that was really needed to make a compelling case. So I think just collaborating with community partners around initiatives and supporting with data is really, really important. Another example that's very much more local, Karen, you were alluding to the group of providers here that are participating in food sovereignty in the Shiprock area. At the very local level, they went to a chapter house meeting and really worked with the community, supported community partners to pass a resolution asking the local store to move the healthy food items towards the front of the store. And that resolution was passed, and the store layout is now changed. So I think it could happen at any of these levels.
I think this program has been the spark. I was there as part of that multidisciplinary team on a Saturday at the chapter house, and the team was very well received and actually went back. And again, it was a chance for staff to be involved with local government officials in a way that they had never been before, and a very positive interaction.
And then we had another person say it was wonderful to learn about this great program. Thank you. And then our next question is, are families eligible for both SNAP benefits and for FVRX, both?
Oh, good question. Good question. We do tell people this FVRX is not income-based, and it does not interfere with their participation in any other program. And I think that's important to communicate to the patients, that we're not picking them out because we think they're particularly vulnerable, and we talk to them about how this benefits the vendors, it benefits the whole community. So they're part of the larger picture, not just vouchers for their family.
All right. And with that, I think we're going to go ahead and wrap it up here. We do have another minute left, and we just want to make sure to be respectful for everybody's time that's on the presentation. Again, we do have another webinar coming up on Wednesday, October 9th at 3 p.m. called Powwow Sweat. CEs will not be offered for that presentation. However, if you did attend today's webinar, you're more than welcome to complete the post-webinar survey that will be emailed out probably within the next hour. And go ahead and get that completed. We'll give everybody about a week to complete the evaluation survey. That'll give us some really good feedback on how we did today, how the presenters did today. And then we'll make sure to get the certificates mailed out to everybody within the next few weeks. And with that, we'll say thank you very much and have yourselves a great day.
Thank you.